Welcome to this webinar examining the nursing management of serious skin infections. I'm Richard Hatchett and I'm a registered nurse and nurse tutor here in the UK and also the senior nurse editor at RCNi. And RCNi is a publishing house and multimedia company linked to the Royal College of Nursing. And we publish 11 journals online and in print. And today we're going to look at a variety of questions that have been sent in linked to serious skin infections with an expert panel. And some of those questions have come from RCNi, from our editorial advisory boards and clinical advisors, and some have been sent in by nurses in practice. So without further ado, let me introduce to you the expert panel. I'm very pleased to welcome Sharon Falconer, who is an OPAT specialist nurse from Aberdeen Royal Infirmary. And OPAT is outpatient parenteral antibiotic therapy, I got that right. And also Malcolm Bain, who is from the medical department at Correvio. So before we go into the questions that have been sent in, it might be useful to define what we mean by serious skin infections.
So this can be anything from cellulitises to wound infections to diabetic ulcers or just general ulcers infections as well. So these are the things that we're actually seeing nowadays that are coming into the departments.
Okay, well the first question we've been asked is, can you outline who are the patients most likely to experience serious skin infections?
Yeah, so this could be a large range of people, from your young to your very elderly as well, and also your obese patients and your intravenous drug abusers as well, your IVDUs. These are patients that we tend to see a lot of these days that are coming in, and also people that have a low immune suppressants as well, people on long-term therapy, life-changing therapy for them as well. We tend to see a lot of these things, cellulitises and wound infections, coming in through possible breaks in the skin from athlete's foot as well, just a gentle break in the skin. We all have bacteria living on our skin 24/7, so any break, this bacteria can actually get in. And we also find that, especially from personal experience, that once you've had a skin and soft tissue infection, you are higher risk from getting it again in that next 5 years as well.
Okay, now we've been asked what are some of the current challenges to nurses in managing serious skin infections?
So when you think about the population that I've just described, these are elderly patients, sometimes obese patients. Maybe they're working, or they have no home as well. They're intravenous drug abusers, or there's homeless patients. These are patients that don't have a permanent residency. They don't want to come into hospital, and also a lot of these patients have very poor venous access. So we need to look at innovative ways of actually giving them antibiotics to get rid of their infections. So this could be using ultrasound machines to actually find decent veins for these patients, and also using antibiotics that's possibly a one-dose antibiotic like dalbavancin. You can just give it as a one dose and that covers them as well. So these are the things that we're actually looking at nowadays.
And Malcolm, did you want to come in there and add to that?
Yeah, I mean, we see several different types of challenge that the nurses are facing. I guess the first is around the type of patients, and they can be quite varied. So the elderly and frail, but also the elderly patients who maybe have Alzheimer's, dementia. Very often these patients can't come in and out of hospital on a daily basis, so they need to be admitted. But that in itself is associated with a risk around these patients being at a greater risk of falls whilst they're in the hospital. But likewise, you can often see a decline in their health and well-being whilst they're in hospital. So the risk associated with that is significant. Likewise, a lot of hospitals around the country now have large populations of IVDU, so drug users, injecting drug users. These patients are, once they initially feel well after that initial dose, are a high chance of self-discharge, but at a substandard treatment. So you may see a reinfection very quickly in these patients and then readmittance again. And then you have a challenge around the homeless population. With no fixed abode, these are excluded from the OPAT services. So how to deal with that group is a challenge. The nurses then have to think about, as Sharon said, the different types of antibiotics that are available to them, whether you're going to treat them multiple times in one day, or treat them with a single dose that day, or a single dose and then send them home. And then on top of that, you then have to consider the costs of the drug. And as we move towards winter, there'll be challenges around bed space and what do you do under those circumstances. So it's a real challenge in deciding which path to take for the nurses.
So a lot of challenges.
Absolutely.
So the next question we have links to that. How nursing has adapted, how is it adapting to meet the needs of these patients? What innovative approaches are out there?
So again, using our ultrasound machines, we can get better access for patients. We have a lot of IV access nurses out there now. And again, with medicine changing all the time, we have drugs that are able to be given. So like I say, dalbavancin, we actually can give as a one dose, and we can discharge our patients, so we don't have to bring them in. They don't have to be admitted. They can get back to their way of life, whatever's good for them, they can get back to. So it prevents us having to do all that. And it puts less pressure on nurses as well, because nurses nowadays, we're all overworked and underpaid.
Yes.
So yeah.
Absolutely. So it sounds like a very fast-paced, fast-moving area of practice. And the question we've been asked is, how can nurses best expand their knowledge base in this area? What resources are out there?
Yeah, so in today's society, we're very lucky. Most people have access to internet, so we have Twitter and Facebook where we can punch in questions and we get lots of answers. We also have access to your IV access nurses out there and antimicrobial stewardships that are going around. They're all things that we can actually access and speak to your managers, and we can all get better educated on these things as well. So it's great.
Do you want to add to that, Malcolm?
Yeah, the one I would recommend is from the British Society of Antimicrobial Chemotherapy, BSAC. They offer an online course called MOOC, which is a massive open online course, and that offers information around antimicrobial resistance and the like.
So there's a great deal of material out there, and if you're interested in more material, resources, CPD articles and so forth, you can go to RCNi.com and see the range of journals that we offer there as well. If you want to subscribe to a journal, go to rcni.com/subscribe, and we have a special offer at the moment. If you choose your journal and go to the checkout and put in the code WEB30, WEB30, it'll give you a 30% discount on an annual subscription, so that's worth having. I'll remind you about that at the end of the webinar as well. So it's back to our questions, and this is about the future and horizons. And what are some of the developments on the horizon you think are going to further meet the needs of these patients?
So we're lucky now in the UK, we have lots of OPAT centres where patients actually don't have to be admitted to hospital beds, so they can attend the clinic centre, get their antibiotics and go back home and do what they normally do, go back to work or carry on caring for who they're caring for, normal living life. But we're also lucky in the fact that we have a lot of medicines changing these days, and we can have dalbavancin, say, it's just a 30-minute infusion that we can give a patient, and they're literally admitted to clinic and then discharged again on the same day. So things are changing all the time, and it's worthwhile keeping an eye on things.
Okay, well, let's move into the questions that we've had sent in from nurses directly in practice. And the first one is, are you guided more by blood results or visual presentation of cellulitis when changing or stopping antibiotics?
It's a good question. A lot of people ask you that. At the end of the day, we have to look at the whole picture. We can't just be guided by the blood results. We have to ask the patient how they're doing. We do their vital signs, their blood pressures, their heart rates, all those, and we do their blood tests as well. So we're monitoring their CRPs and things like that. So we're looking at the whole picture, and if we're happy and this wound or the cellulitis site is looking good, then we will decide and change their antibiotics, but not until the whole picture's there, then we can make that decision. But it's not one thing at all.
Okay, so the next question is, what is the most appropriate follow-up when a patient doesn't need acute admission?
Okay, so yeah, in my service, I prefer to use a one-to-one. I decide on the patient what kind of follow-up is good for them, ask them what's good for them as well, look at the infection that they have. So if this is someone that is not able to come in every day, but we feel they need to, then we will push and ask them to come in every day. But these are patients that we can maybe talk to using the telephone these days as well. So we can give them a dose of antibiotic and we'll follow them up through that. Also, again, we'll look at our management, our consultants, and see what they would like as well. It's not all down on my shoulders. We do look at the whole picture, see what the consultant wants, see what the patient wants, and take it all into case. Some of our patients are reviewed every 2 days or maybe even once a week. And again, it depends on the infection that they have. But predominantly things, we generally have a conversation with them every couple of days.
So another question we've had from our nurses in practice are, if a client presents with a rash for no apparent reason but feels ill, how does one differentiate between allergy or similar and infection? And what tests should be done if infection is suspected?
Okay, again, so we need to think about the patient to do their vital signs, their heart rate, their temperature, those sort of things are going to let us know. But further on from that, we need to start thinking about blood tests, doing this ESR or their CRP, and waiting for those results to come back as well. And that will let us know if it's actually an infection or if it's just an allergy.
Okay. Now, the next question is quite a long one. It comes from care of the elderly. And it says, I work in a care home nursing elderly people with dementia who develop skin infections such as cellulitis and/or boils, etc. And it's very difficult to treat them due to their cognitive impairment and challenging behaviour, especially when infections occur. And also hospital admission could prove inappropriate due to the change of environment, which could upset them more. Could we find a way to treat these people effectively in their homes or in the care of the elderly setting? Yeah. Sometimes the oral antibiotics are very difficult to administer due to their refusal.
Personally, I don't look after patients in care homes, so it's really hard to give an answer for that definitive. But when I look at the patients that we do look after, these are patients that have dementia, as you say, so maybe just bringing them in for a 30-minute infusion or even giving them a 30-minute infusion in their care home. It will save them having to come into hospital, so it will save them having to miss doses, things like that, if they're not willing to take oral medications or unable to take oral medications. This is something that's going to make life easier for them. And then we can do a follow-up over the telephone with the ward manager or the nursing staff that are in charge that day and give them access to a phone number that they can contact us if there is any changes in their circumstances. And we can either pop along to see them or, if able, they can come and see us as well in clinic. But it would save them having to be admitted to hospital. So yeah, quite rightly, we need to stop those things happening as well.
And the final question that's been sent in from our nurses in practice for both of you, how can it be possible to maintain continuity of care once patients are out of hospital and to prevent the condition returning?
Again, from personal experience, we are very lucky, or I am very lucky in the OPAT service I run. Our patients will have phone numbers, so we can phone them up, they phone us up, they have access to a phone number. Although I'm not there 24 hours a day, they also have an outside number that they can actually phone to contact the infectious diseases ward if they have any problems. So, and they're normally given a follow-up appointment in clinic as well, but if they're unable to attend the clinic appointment, they will come back and see us when it's available for them.
Okay, do you want to expand on that?
Yeah, I would just agree with Sharon that the treating physician, it's important that they maintain some sort of contact, some sort of continuity, whether that's by phone or getting the patient to come in once more. And also the situation now is such that there are the medications out there that you probably have to tailor that medication for that patient. If they're unlikely to come back, then that will influence their decision. But likewise, if you've got somebody who's very engaged, then bringing them back maybe in 3 days or something might be an option.
Okay, well, thank you very much. That's extremely useful. I hope you enjoyed the webinar. Just remember the promotional code WEB30. Go to rcni.com/subscribe if you want to subscribe to a journal, WEB30. And thank you very much for watching.